refraction, whether it's in the center of the pupil.
So you have to consider the smallest thing.
When you are shining a torch, normally eye movements, you can torch. Follow my torch, like that. It helps you to shine the torch into the pupil. So management, mild retraction does not require treatment. May improve spontaneously on its own. Surgery sequence of surgical procedures should be as follows: orbital decompression, strabismus procedure, then eyelid. Then eyelid surgery. The orbital decompression, they have to remove some of the tissues. That's which are pushing the eyeball forward. Then after that, that's when you go to muscles. That problems with muscles, you correct that. And the last three.
Maybe. Jonathan, I want to say something, sir. We can proceed.
So that's normally what you do. That molarectomy, molar's muscle, cutting of molar's muscle is molarectomy. Disinsertion of molar's muscle for lid retraction. You see, that's when there's really retraction. If you disinsert, you are removing that retraction part. It goes back. And the recession of the lower eyelid retraction, retractors. There's also botulinum toxin injection, which closes the eyelid. Proptosis, from the word protruding. Forward displacement of the globe is proptosis. I think as you are studying these definitions, you have to be very, very clear. You have to learn them. Because there's nothing in messing your exam. What is this condition called? I don't know. But you are seeing there is such a thing. Read. When you are reading, please follow. Definition: forward displacement of the globe is proptosis. Maybe axial, which means centrally, or unilateral or bilateral. Severe proptosis may compromise lid closure with resultant exposure keratopathy. If there is a problem of lid closure, you are going to have exposure keratopathy. You are going to have corneal ulceration, obviously, and infection. These follow one after another. First is exposure, then it goes to corneal ulceration, then it gets infected. Proptosis measurement with a plastic ruler. You check the millimeters from this side, then you go and check the other eye. These are small millimeters.
So this one was 1.5?
1.5, But you have to ask the patient to look straight ahead. Then you measure from the side. If there is a difference between the two eyes, it will come out straightforward. Exothermometer. Proptosis measurement with this, it also gives you there's a reflection into the machine. This one is obviously proptosis. Severe proptosis. Such cases, normally, what do you think? Cause
Cause for proptosis. Mostly should be in the orbit.
yes, okay, it's in the orbit, yes.
There can be some contents in the orbit.
Like what? We've been talking about this here, not some content.
Okay, orbitocellulite.
Exactly, but there is no cellulitis here.
Then
There is no cellulitis. This is not
Thyroid.
thyroid eye disease. Before you say cellulitis, but there is no sign of inflammation here. So this is just thyroid eye disease. If there were signs of inflammation, there would be redness everywhere like that. Then you can, yes. This is a sad issue. That keratitis infection and keratitis. This is now blind eye, blind eyes, not one. Exposure keratopathy, because the lids were unable to close to protect the eye. That's the issue which is
so there was an ulcer,
yes. Yes. The lids were unable to close. You can see the importance of the lids. Once you have severe like that, if you are unable to close, you are going to end up like the other pitch. You end up like that. And it's sad. Management. Systemic steroids useful in rapidly progressive and painful proptosis. Rapidly progressive and painful proptosis, it means there is inflammation within the orbit. So you that one reduces the congestion which is there.
There's a question. Is thyroid eye disease permanent?
Sorry, there?
Is thyroid eye disease permanent?
Yes. Yes, it is. Meaning permanent, it can't be treated or can be treated.
Let her give emphasis.
No, once you have it, you have had it. You have it. So people have to look out for the side effects of that thyroid eye disease. Some, if you notice, they are controllable if you start early. And that way you manage the patient so that they have some vision remaining with them. There's nothing more devastating like loss of vision, which we take for granted, But once they tell you you're blind, you had the chance to see. It's terrible. Even going to toilet, you have to be accompanied. It's a sad situation. So systemic steroids useful in rapid, progressive, and painful proptosis during the congestive stage. Oral prednisolone, these are also oral steroids, 60 to 80 milligrams, when there is reduction in discomfort, chemosis, and periorbital edema. Dose should be slowly reduced. Methylprednisolone, these are all steroids. All these drugs, prednisolone, methylprednisolone, they are all steroids. You can give oral, IV methylprednisolone, you give it that way to control this. But if you're going to give this, it means there is a chance that the patient will be able to see, isn't it? If there is no chance and you subject a patient to this, it means you're just raising hope for someone for nothing. So whatever stage you take here, you have to take it really seriously and discuss it with the patient frankly. At this stage, no one wants cosmetic. No, but if he's blind, he's blind. These steroids reduce this optic nerve compression, or the edema in the orbit, and the careful monitoring necessary because of the potential cardiovascular risks. Put yourself on steroids for a long time, there are always problems with the steroids. Radiotherapy, combined therapy with irradiation and what happened? Radiotherapy, combined therapy, irradiation, and azathioprine, low dose, with a low dose pressure. This or that drug, rituximab, it tends to reduce the compression. Surgical decompression of the orbit may be considered as a primary procedure after failure of the therapies, where you do one wall decompression or deep lateral wall decompression. You have to cut out tissues out to decompress because of the edema which is in the orbit. That edema leads to compression of the optic nerve and ultimately to blindness. When you reach there, you know it's tough. Surgical decompression of the orbit, 3-wall. You cut out the medial, lateral, and the floor. Gives 6 to 10 millimeters reduction in proptosis. 4-wall decompression, medial, lateral, floor, and roof. This is for very severe proptosis. And normally these are surgeries done by people who have had a lot of experience in this field. They are removing all the 4 walls so that the eyeball can fall back instead of the whole eye protruding out. So this 4-wall decompression can be done in very severe proptosis. Restrictive myopathy. Between 30 and 50% of patients with thyroid eye disease develop ophthalmoplegia, inability to move the eyeball. The eyeball is moved by the muscles, the 6 muscles, isn't it? We've got the lateral, medial, superior, inferior, and the oblique, inferior and superior oblique muscles, 6 muscles. So when there is a problem with muscles, they can't turn properly. That's what is referred to as restrictive myopathy. So between 30 and 50% of patients with thyroid eye disease develop ophthalmoplegia. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. Intraocular pressure in up gaze due to ocular compression by the fibrotic inferior rectus. Hmm? 5 minutes more. Don't worry. Oh, there's a Monday, don't worry. We can continue Monday. It's not problem. Picture in the face. This is unable to see. Restrictive myopathy. Effective elevation of the left eye. This one is able to elevate. But you think this is normal. But when you compare with this patient is supposed to be looking up. It means there is defective elevation here. Contracture of the inferior muscle, inferior rectus muscle. This can't lift up.
What's the name of this one?
This one is able to look down, but not that one. Defective depression of the right eye. There is no time when you can have one eye looking down and one eye up. You see the point?
One must be in primary.
Yes. No, both are supposed to be going together.
Oh, yes.
Both. Both are supposed to be going together. But this is the same patient we saw. So has got it. We go back. It's the same patient, Roma. Restriction in up gaze here. Fibrosis of the inferior rectus. This is Mwalero Leshakunyugo. Fibrosis of the inferior rectus. Next one. Treatment, surgery. Indications and criteria: diplopia in primary or reading positions of gaze. Angle of elevation should be stable and disease should be in a quiet stage. And two criteria is met. Patient's diplopia should be managed with the prisms. So you don't go in until this criteria is met. They've got a problem, we know. If you're going to have diplopia in a primary position, it means things are double as they are looking straight. You can't leave it like that. Or in a reading position. You know. Once patients have got that, they need surgery to correct. It's really very devastating, you know. In a primary position, we're going to double. It went away. Any questions there?
Okay, so I shall have 2 minutes.
Oh.
So just in case they have questions.
Oh, okay.
I don't know if we can start another meeting to handle the questions or.
I don't know. Which time, Shima?
It's 12:31.
32. I think it's they have to maybe they have questions, you know. It's better we clear the questions. Then the rest we can follow up tomorrow. Oh, not
Monday.
Tomorrow, Monday. Yeah, I think we can't just let them go. Let them. Let's hear what questions they've got. At least batch clarification over this point here.
Any questions?
Ladies and gentlemen, any questions? Unfortunately, the lecture is very long. Okay.
Optic neuropathy.
Optic neuropathy. This is it. There's no capping there, but it's all white. Optic atrophy. That's the optic disc swelling. But it can be seen elevated. Optic atrophy, they will end up with poor vision, obviously. The atrophy is the optic fibers. From the cells, rods and cones, it means vision in that eye will be poor.
Okay, before I cut, you can say your goodbyes.
Monday, we'll finish off Monday and start another lecture. Tomorrow,
It's
Saturday, sort out your requirements and a bit of rest. But read, ladies and gentlemen. This is the chance. Get your textbook, which I believe you have. So